Thank you very much, John. Welcome everyone to the second installment of our post-pandemic webinar series. Today's program is on healthcare design, and we have three panelists who are experts in the topic, as well as being owners' representatives and practitioners. So we have a variety of representation on today's panel, all of our members being members of, all of our participants being members of AIA New Jersey. Our course today is approved for 1 AIA continuing education credit with health, safety, and welfare. Healthcare design in a post-pandemic world. The COVID-19 pandemic has risked the public's health and safety in buildings across the U.S. and beyond. This program is intended to provide design professionals, employers, building owners, facility managers, and the public with tools and resources for reducing risk when reoccupying buildings during pandemic and in developing safer buildings in the future. Expert panelists include award-winning registered architects who specialize in healthcare design, registered architects who run healthcare facilities, and registered architects who are also registered medical professionals. The panel will share strategies based on emerging science, infectious disease transmission data, epidemiological models, and research. Program content will provide processes and strategies for protecting the health, safety, and welfare of the public while resuming services. This program will address changes to healthcare buildings' form and function to better protect occupants from the spread of pathogens. Our learning objectives have been sent into AIA National, and at the conclusion of this course, everyone who has stayed on for the hour-long webinar will be sent a survey. When you complete that survey, AIA New Jersey will be processing your membership number for continuing education credit. Our first speaker is AIA New Jersey past president Ben Lee. Ben, would you please introduce yourself?
Thank you, Stacy. I'm Ben Lee, principal at NK Architects with a Master in Management as well as a Bachelor in Architecture. I'm a board certified healthcare architect in charge of NK healthcare sector for the past 30 years. I'm a registered architect in 25 states and DC with a major project throughout the country. And currently, my focus is on advocacy for health and wellness in the built environment to improve population health. Next one.
Thank you, Ben. Next up, we have Hollis Madera. Holly, would you please introduce yourself?
Sure. Good afternoon, everyone. I'm Holly Madera. I'm the practice leader for health at HDR's Princeton office. I am both a registered architect and a registered nurse. I've been working in the healthcare field for over 30 years, both in architecture firms and on the hospital side in nursing and in administration. And my focus really is on operations and how the architecture can enhance that.
Thank you, Holly. And last on our panel, we have Donna Trezano, past president of AIA Central Jersey. Donna, can you please introduce yourself?
Sure. Hi, everyone. I'm Donna Trezano. I'm a licensed architect in 3 states, New York, New Jersey, and Pennsylvania. I'm a project manager with Robert Wood Johnson Barnabas Health. As Stacy mentioned, I've been active in AIA Central New Jersey for about 2 decades, as well as the Healthcare Facilities Management Society of New Jersey. Happy to be here.
Thank you, Donna. And myself, I'm a past president of AIA New Jersey and the Architects League. My participation in this webinar series is as a representative of the AIA New Jersey Public Awareness Committee. We are providing these resources not only for our members for continuing education and professional advancement, but also for the general population who works and interacts with the sectors that we have represented in our webinar series. And we're excited to be able to bring something like this to our members and to the public. The webinar series was developed for developers, business owners, facility managers, operators, realtors, and users to assist them in understanding facility design changes that can be anticipated in our post-pandemic world. Each webinar will focus on a different building business type and feature a panel of architects experienced in that sector. To register for additional webinars in the series, you can visit the link here, which you will get a copy of this when the program is over. And we also are advertising regularly through our newsletter, which came out earlier this morning, and on our social media. The programs that we have include multifamily buildings in a post-pandemic world, which took place on October 22nd and will be available for you to view in a recorded format. Today's webinar on healthcare design. Next, on November 19th, we have restaurant, retail, and commercial building design. December 3rd, school and daycare design, and December 17th, contract interior design. We hope you will join us for the full series. Okay, now we are going to switch over to Ben sharing his screen and starting his presentation.
Well, thank you for attending. It is important for us to cope with the COVID-19 right now, but as well as how we can prepare ourselves for the future. So what I will do is provide a broad outlook of a pandemic and how we as healthcare architects prepare design for the future. And Donna will be providing you with the owner's perspective, and Holly will explain a case study that she went through with the Valley Hospital. So in healthcare environment, it's very important for us to deal with the facts, the data, and the statistic. So on the left-hand side is a chart from Johns Hopkins University, shows 10 of the worst performing countries in the world. And you probably recognize the curve that's in green, which is USA. And we went through the epicenter in the Northeast, and then we threw the epic through the middle of the country. And this chart is the end of October. And we are climbing to the level of 98,000 as far as last Friday for cases. And so far, I think most of you are aware, approximately 9.8 million in cases, 230,000 in death. So on the chart on the right, it's a way to show how that dispersed throughout the world. And you can see I circle on the right 3 countries. That's basically the US in the green, and the India that's in orange, and Brazil. So the chart tells the story of how we as a nation control the COVID-19. So I'm curiously why there's a public health crisis in US. Because in the past 30 years, at the NK, we have designed and built School of Public Health. On the top right is Stratford campus for osteopath and public health. And the middle one is about 20 years ago for UNDMJ, now part of Rutgers, for Piscataway campus, as well as something we currently completed at the William Patterson College with a public health program. So there's no lack of education in public health. In fact, in every one of these schools, they talk about having a big one all the time. That's way before Bill Gates, had his TED Talk 5 years ago. So exactly, what did go wrong? I will give you a good example since I was born in Taiwan. And Taiwan were able to control the virus very quickly with only a handful of cases. In fact, without any lockdown at all. Can you imagine no lockdown and the controlling the virus? And the vice president of Taiwan happened to be a PhD graduate of School of Public Health from Johns Hopkins University. So when you have someone at the leadership level can guide the process with a successful maintenance and of the disease. And also I want to talk quickly about the CDC, Center for Disease Control in US. When my son went to college at Emory for his first year, and Emory campus is right next to CDC. And that brick building that you see in the front was the original facility. And when they built this high-rise massive campus, I mean, I was truly impressed with how US are investing in public health. And they do go through yearly pandemic playbook. However, in the past 3-4 years, funding were cut, staff were cut, and somehow we kind of lost the leadership from the CDC as a voice for public health. So prior to US experience, include Ebola was something that's in 2014 to 2015, US helped the World Health Organization to stamp out the Ebola in West Africa. Unfortunately, there were some cases came to US first in Texas. And as the end result, the government decided to provide grant for many hospitals to build so-called these infection control units. But those budgets were so far and small. And also we went through H1N1, which is swine flu that's in US. And there were 60 million cases and plus 274,000 people hospitalized, but with about 12,469 deaths. So we have that experience. Somehow we're not reapplying that. And then other events, including terrorism after 9/11, when we have to start redesigning our ED, and we worry about terrorism through anthrax to attack our mechanical systems and all that. So we've gone through a lot of precautions. And one thing with US healthcare delivery we have to acknowledge is that we spend about 18% and will be approaching 20% of our GDP for healthcare, and while we have the poorest performance. Because of the cost cutting, we've been cutting hospital beds from urban cities. And then also we have closed many of the rural hospitals, which is very important in coping with pandemic, especially now it's widespread through the country. New York and New Jersey happen to be the epicenter. New York is the chart on the right. I try to reduce the scale for New Jersey so it doesn't look as big. And my gather of resource right now, New York, New Jersey only went through the so-called the first wave, and they start climbing. And yesterday there was a report from New Jersey Department of Health anticipating for so-called the second wave for the tri-state area, January 2021. So in prepare for this epidemic that NK was involved with Greater New York Hospital Association to create some additional bed, which I will go through some of the detail later. And we are lucky to have the Army Corps of Engineers to build a field hospital at Javits Center. because we as healthcare design profession usually held a very high standard as far as following guideline requirement. And as a government agency, they are able to perform things in a more drastic way quickly. And therefore, professional liability compliance is quite important. You know, we are very fortunate at New Jersey that a few years ago, we passed the Good Samaritan's Law to help architects in case of liability responsibility. So this is the evaluation of a facility for non-crucial beds in New York. And of course, the first task is to look at the physical environment. And of course, the best arrangement ultimately is for single private room. But the most important with the infection control is the chart on the right. It's the mechanical systems. So it is very important for us to follow the CDC and ASHRAE standards for infection control and to deal with air change and to deal with air filtration, and as well as creating a negative air environment. So we're currently working on a project for a VA medical center in Washington, DC. And the project is to improve their medical isolation, medical ICU. And it's important to analyze the project starting from the patient flow into the hospital and how it worked through the emergency department, or maybe sometimes the best way to do is bypass the emergency department into this unit. And I will talk also a little bit about single patient room and how we cope with nursing homes. So on the left-hand side is what we initially proposed for the VA Medical Center with the typical MICU room. And basically it's nurses stationed by the entrance observing 2 patients at the time, and with the bathroom on the outboard. And so it's quite ample space following the VA standard. However, dealing with COVID cases, you probably saw a lot of photographs of hospitals with the equipments filled the hallway. And I was reluctant on showing a photograph because these are actually a fire code violation to have monitors and the equipments block the hallway for egress purpose. So in our case here, we were able to design, starting with an alcove and as a result into an anteroom. You know, keep in mind, this is not the true so-called isolation room, because a true isolation room requires a separate anteroom to each individual room. This is in case for them to anticipate for a pandemic. So what we have developed is an anti-space. This is for the protection of the staff. And the importance is to designing of a mechanical system that's actually in 3 tiers. Bathroom will be exhausted, and the isolation room will be a primary negative air with the right amount of air change. And then the staff is protected in this anteroom, and with the ability to hook up monitors and equipments out in the anteroom without exposing themselves continuously into the patient space. And also there's a sliding door in the front, so there's negative air without contaminating the entire nursing unit. So as far as designing for the entire nursing unit, we need to develop with flexibility in mind, because we're not dealing with pandemic all the time. So it needs to function as a conventional MICU. So some of the rooms that's remain in light pink, they are conventional rooms, and with the heavier red and heavier pink to be the isolation room. So the key is for infection control is we need to design for flexibility, and also design for staffing patterns. For ICU, for 2-to-1 ratio of observing 2 rooms, but when it's not in use, they need to have alternative nurses station. And you probably heard many cases arise for a nursing home design. Even when we went through some of the best scenario is, we get away from design of, side-by-side beds for typical nursing a home. And over time, we have developed toe-to-toe. Maybe the patient head is 15 or 20 feet away from each other. But the physical solution doesn't resolve everything, but it's important to have testing, training, operation as an integral part of this. So we are designing a nursing home in the future with the so-called this private residence rooms with its own bathroom. And for majority of the rooms, in few cases that people may want to share a semi-private suite with husband, wife, or companion. So we allow a separate private room with the shared corridors and the separate and the one bathroom to save costs. So talking about hospitals and so on, we cannot neglect behavioral health. So over years, we have done many behavioral health throughout the country, because that needs to be an integral part of the Affordable Care Act, to not just taking care of the physical health, but to take care of the mental health. So during the pandemic, it's necessary to have quick access to these facilities. And what we have been engaged now is for post-pandemic, we are developing easy access, walk-in urgent care kind of medical environment for the patient. Finally, I want to just close out to emphasize on the future adoption that telemedicine is here, and the people are using it. And the telehealth for mental health finally got approved by CMS as a viable way of overcoming HIPAA requirement. And the population health is in play, because we gradually changing from fee-for-service to value-based, because the more you have service doesn't mean you have a better outcome. So we at NK and our NK staff is working closely with our local communities to develop the necessary healthcare determinants to improve the overall outcome, including green space, walkable city, food resource, social viability, etc. The emphasis to develop a healthy environment to improve population health. I'll turn over to Donna.
Thank you, Ben. 2020 has tested our healthcare infrastructure, its ability to adapt, flex, and implement emergency solutions. In order to remain in front of the public health crisis, healthcare organizations, big and small, have had to identify and integrate strategies with a holistic approach. This includes the allocation of physical space, the integration of a robust infrastructure, the employment of relevant processes, and earning the public's trust. The next few slides include common themes and potential strategies to navigate the pandemic. But as we remain in the midst of it, it could be some time until we know the full impact of these strategies, including whether codes will change. The important takeaway is that any strategy has several variables to consider. Healthcare organizations have had to identify potential process disruptions and assess their capabilities to achieve flexibility safely. Strategic planning relies on successfully identifying personnel and financial resources, technological innovations, process improvements, and prioritizing in order to guide implementation. For large or small healthcare groups, this might include assigning dedicated personnel for an emergency response team, keeping lines of communication open both internally and externally, as well as having a plan B, C, and D. A critical component of strategic planning is also evaluating inventory and resources, including identifying bed types and quantities, such as those in the ICU, the ED, and medical surge units, sizing for critical care rooms and providing infrastructure in the event of a surge, identifying spaces that could be transformed into clinical areas during that surge, evaluating the ability to shift entire departments into temporary spaces, repurposing existing clinical spaces such as a prep hold into dedicated COVID areas, as well as evaluating outpatient facilities can remain operational or become temporary inpatient resources. Other components include providing expansion of telemedicine services, which will likely have an impact on the types and sizes of healthcare spaces will be in the future. Organizations are reviewing operations and evaluating financial impacts due to the diminished revenue, increased in patient costs. As many of us have seen in the news cycles, healthcare organizations, large and small, have had to identify potential supply chain challenges as well as opportunities. A strategic plan might include managing PPE with a just-in-time approach, as well as having a 2 or 3 month supply on hand. Forming new partnerships and leveraging those partnerships to pool resources or increase buying power can be beneficial to both patient care as well as the bottom line. The phrase, "people are our greatest resource," has been said before, and in response to the pandemic, organizations are reviewing staffing availability, staggering shifts, cross-training, and creating float pools. They are also providing daycare, areas of respite, and mental health services.
Hey, Donna, sorry to interrupt.
Yes.
You're not sharing your screen, just so you know.
Oh, hold on one sec.
Take your time, no problem.
Do you see it now?
Yes.
Yep, you're good now.
Okay, thank you. I'm sorry, everyone. There are several infrastructure strategies that can be considered, but admittedly, some of these are more viable than others, especially if you were a building owner versus a building tenant. In general, healthcare facilities have had to be effective with negative pressure rooms, including increasing the number of or grouping them in order to cohort patients in an effort to reduce virus transmission. There's also been an effort to increase the number of air changes in areas such as ED patient bays and provide improved HVAC filtration, either through the main system or with mobile equipment. Other airflow components include the proper location of exhaust and return diffusers and potentially integrating UV light within the mechanical equipment itself. Emergency power continues to be important to maintain the continued operation of medical equipment. Availability and redundancy contribute to a robust infrastructure. Therefore, consideration is being given to provide additional emergency power in locations beyond where the code might prescribe. This includes areas deemed as potential clinical surge spaces, such as conference rooms, dining areas, and large wait areas. With increased patient monitoring, having decentralized spaces for equipment charging can be beneficial, as well as upsizing an emergency generator or obtaining a mobile one. When it comes to medical gas, air, and plumbing, organizations are evaluating the size of oxygen source, the physical pipes that carry it, and the system surge capacity. They are also determining how to be efficiently provide additional hand washing locations and even install touchless fixtures. There have been some documentation about the benefits of replacing blowout type hand dryers with paper towel dispensers to reduce aerosol transmission. From a facility EVS perspective, improving and or increasing frequency of cleaning protocols are also imperative. And finally, technology has played an important role in expanding telehealth, as Ben had mentioned. It has also provided the ability to do more remotely, including registration and discharge. During the spring surge, technology such as walkie-talkies and baby monitors were used by patients and clinical staff to reduce in-person contact in the nursing units. Facilities are also strengthening their own networks and encouraging the use of personal devices. Technology can be used to monitor critical infrastructure, manage PPE, and other critical resources during a surge when shortages are likely. Limiting person-to-person contact by installing self-kiosks for registration and dining areas, as well as integrating automatic technology at doors, as well as ability to voice commands, is important. Planning, architecture, and design also play a role and are critical in strategic planning, especially when reducing the simultaneous occupancy, such as integrating a pod arrangement to facilitate triaging presumed and confirmed COVID patients from others, providing the ability to compartmentalize inpatient units in designated support spaces, integrating anterooms at isolation rooms, operating rooms, and procedure spaces, designing decentralized nurse stations, charting, and staff support areas such as lockers and lounges, and locating subway rooms closer to the point of care. An important aspect that we also saw during the spring surge was the ability for clinicians to visualize and monitor patients without entering the room. That would help reduce PPE usage as well as virus exposure. Glass within patient room doors or at corridor touchdown workstations can provide this flexibility. Throughput and patient transport should also be considered. Encourage one-way flow through corridors or work areas, but coordinate with egress requirements will need to be considered. Sometimes it's feasible to dedicate an elevator which either stops at certain floors or used specifically for COVID patient transport. Also reimagine outdoor areas as extension of public spaces. Other items to consider includes furniture layout types and finished materials. In some circumstances, bench seating is being replaced with single-user seating. Non-porous materials has always been important in healthcare, as well as materials that can be easily cleaned and disinfected. Consider changing existing door hardware to copper or other metals that naturally resist bacteria in high-use clinical settings. And there are other strategies that are not as cost prohibitive, such as limiting personal items of employees and patients, providing wayfinding or visual cues to reduce the need for staff visitor contact, and using transparent barriers between workstations if social distancing is not possible. Communication is very important, especially in public health crisis. Emergency preparedness and process improvement communication is always critical. This includes both internal and external communication of policies, best practice, and data-driven facts. Leverage technology to target communication via various platforms. We have seen competing organizations sharing knowledge, including the pharmaceutical companies developing a vaccine. Following the statewide lockdown orders, communicating the importance of preventative care has been critical for public health as well. Communication can make or break a strategic plan, so no matter how complex or simple that plan might be, effective and efficient communication is important. And as we continue to experience the pandemic, critically evaluating your organization and remaining informed will prove valuable. Some healthcare organizations will be able to rely on internal processes already in place, including being a high reliability organization, while others might need to further evaluate their goals, performance, and implementation. I believe that in order for healthcare organizations to provide outstanding and safe patient care, as well as remain relevant during a healthcare crisis or otherwise, an environment must exist that empowers both patients and staff, facilitates innovation, and promotes flexibility, adaptability, and resiliency. As noted in my first slide, this requires a holistic approach. Next, Holly will review a case study that integrates many of the characteristics that Ben and I have already described.
Thank you, Donna. Hope everyone can see the screen. So as Donna said, I'd like to share a case study with you today of a project that's in our office and it is currently under construction.
Hey, Holly, real quick, if you can, up at the top of your screen there, click on display settings.
You got it, yep.
And then flip swap presenter and slideshow.
It's not letting me do it.
You're currently sharing the notes screen and not.
Yeah, and it didn't do that before, huh?
No, you were fine before.
Let's.
While you're getting set up, Ben, there was a quick question for you.
Yes.
With all of this HVAC control required to truly separate these rooms from ante-rooms, vestibules, and hallways, do we need to provide deeper spaces above the ceilings to handle all the increased ductwork? Can you share any rule of thumb for this requirement?
Yes, I see the question is from Dennis Link. He used to work for NK. Yes, you need to have a deeper ceiling, but you can develop a strategies, by first treating the bathroom exhaust as part of your negative, airflow, and then you have to you do need to have separate ductwork for the patient area as well as the anteroom. Yes, it is going to be more complicated and require deeper ceiling space, and also require a lot of tube connections between pumps, monitors, and all that to bring to the anteroom. So that's the fun part of healthcare is we have been challenged with all these requirements all the time.
Thanks, Ben. Go ahead, Holly. You're good now.
Good, great, awesome. Okay, so the learning objective here really is to learn how some operational processes influence a smart design that's enabling Valley Health, a local healthcare facility in New Jersey, to prepare and adapt for much of the post-pandemic care. They are on a journey as well to become a high reliable organization. And when they first began to engage us in the design of their project, they wanted a process that would integrate into that culture. So because of their focuses on process and operations, we feel this really has influenced their design and set them up for success. So a little bit more about New Valley Hospital. It is currently under construction in Paramus, New Jersey. The existing facility is in Ridgewood, New Jersey, both in Bergen County, just 2.5 miles from each other. It is a inpatient facility only, and that's important to note. 288 medical, surgical, critical care flex beds, and I'll talk a little bit more about the flex piece of that later. About a 25-room procedural suite, a women's and children's tower, that is one of their signature service lines, as well as a full ED and the associated support spaces that you would expect to see. So what's unique about Valley Hospital is that this project was designed in 2017 prior to the pandemic with no foresight of where we would be today. And we used a process called the ThreeP, and I'll touch about that in a little bit as well. And then the construction of this project started really just right before the height of the pandemic. And it is expected to be on target to complete construction by the end of 2023. And important to note that the pandemic hasn't affected the construction of this at all. So everyone feels that we're going to be completely on schedule. This is a recent picture of the state of the construction right now. You can see the steel is pretty far along. So I'm going to talk a little bit more about the ThreeP process. So as I mentioned before, it's a process-driven approach. If you're not familiar with what a ThreeP is, it originally derived from Toyota manufacturing. More popular in the 80s, has progressed to its application to healthcare, but it is embedded with Lean Six Sigma philosophies, of course. And this methodology, what's important to note is it really encourages teams to envision a future of healthcare and how they would work together. It is patient-centric, and the P stand for production, preparation, and process. So key to this success of this process really is the participants. The ideal team is a multidisciplinary team. And what I mean by that is it's really a cross-section of all the hospital staff that touch the care of the patient, affect operations, and it includes not only nursing, but physicians, frontline workers, support services, administrators as well. And they're all engaged to work together to understand how they work today, envision a future optimum process, And this allows them to create a vision for their future hospital plan. So the first step in this really is to have this multidisciplinary team map out at a high level what their current process is. And in this case, it was a patient on admission to discharge through this inpatient facility, and to understand what that looks like for each other. Knowing what they currently work like today helps them to understand where their improvements need to be, where all the waste is, and helps them envision what an optimal process would be in the future. So you can see the difference in the two images, how the optimum future state workflow is more simplified and streamlined. Teams are encouraged, the sky's the limit here. Teams are asked to determine what the ideal future process is so that we can plan for it. So the next step is taking that optimum process and using it as a guide to help determine what that future plan should be. So in the photo, you see a group of participants putting together a surgical suite with chips of space that represent programs of spaces, and the end result is a two-dimensional drawing of the plan. So next, those 2D plans are taken by the teams, and quarter scale, three-dimensional plans of their departments were built so that they could further envision those spaces more three-dimensionally and map out the 7 flows of healthcare, determining how medications would travel, equipment, supplies, how they would travel, how staff and patients would circulate. This allowed the team to make additional changes to the planning because they could see them more three-dimensionally. They've also mocked up typical rooms. You see the photo there illustrates the emergency department, enough to understand this is the size of the room they can expect, and test it with the equipment that they knew needed to go in it, and even do some trial simulations as well. So again, the 3P process, it really encourages revolutionary change. It's a highly facilitated process. It allows the teams to investigate the what ifs and what could possibly be for the future. And for Valley Health, it's really resulted in group consensus of an optimal way to work, a healthcare design that embraces the workflow, and plans that were created with flexibility and adaptability in mind. And this is what has helped change to occur easily. HDR has used this process on several projects. We've learned a lot from this, and in our office today, we refer to it as an immersive design event. So I'm going to take 2 departments and use some examples from those 2 departments and the design elements that the team had come up with. So I'm going to explore the emergency department first. And some of the key elements in their ED planning included the isolation and decontamination area, a pod design, a telemedicine zone, and a dedicated stroke IR room within the ED, as well as I'll touch on the mechanical design. So first, the ED was designed with the decontamination area. A lot of time was spent on the details of that area. That's item number 1 on your screen. To be sure that donning and doffing worked correctly and the circulation worked correctly. So right off the emergency entry. The second item was the isolation zone or the isolation bar. That's item number 2. And that is right off the ambulance entrance. So you can see there's a back entry into rooms that are right off the pod design that allows you to enter those rooms without entering the main ED. And that zone is negative pressure compatible. The ED itself was designed with 5 pods. They are all self-supporting, all with individual medication areas, clean supply areas, equipment areas. So it's ideal if you need to cohort or isolate patients in one area without infecting the entire emergency department. And then item number 4 is a telemedicine area. So they had the foresight to think about telemedicine even before where we are today, and it will be a value for them in the future. We're still working out the processes of what that will actually look like, but that zone has been reserved for that. And then lastly, they implemented a stroke IR room right in the emergency department. That's item number 5 on the screen. And although the initial intent was to really make that embolization time minimal and save the patient's life, the benefit of having it right there is we don't have to transport a patient to another area in the hospital who may be infectious and infect another floor. So quickly, with the design of the mechanical systems, I've already mentioned the isolation bar. They call that mode 1. Mode 2 is providing additional rooms facing into pods B and C on the plan that will allow isolation rooms to increase from 6 to 9. And then lastly, mode 3 is the ED would be fully exhausted. And hopefully this slide shows the differences a little bit more visually. So you see the colors where number 1 is your normal mode. Number 2 has the ability to increase for a surge mode, increase those numbers of isolation rooms. And then lastly, number 3, mode 3 is the full exhaust mode in the blue. So let's talk a little bit about the patient room and the inpatient bed design. So the key features of the inpatient bed units are all identical. The units itself are identical, and the rooms are all identical. One of the key elements here is the use of a prefabricated head wall. There are choices for staff work and staff respite that are important to staff, especially today, for staff satisfaction and allow for emotional rest. And then lastly, I'll touch on the mechanical systems as well. So let's take a look at the patient unit. Again, focusing on item number 1, they're all identical. There are 36 acute care beds on each unit. Number 2 shows the variability in work areas. So there's 2 central workstations per unit. Behind those central workstations are team rooms, and there is at least 1 additional room for use for touchdown. And then each patient room as well has a decentralized station. So there's varied places for staff to work and spread out. And then lastly, number 3, you see that there are 2 different areas in the plan, both in the front and the back of the unit for staff respite. So next, just touch a little bit on the patient room itself. Again, it's sized for critical care use, and the key here is the prefabricated head wall. So this integration of a prefabricated head wall has really allowed the owner to upgrade each of the medical surgical head walls to critical care levels during the pandemic and during construction easily. That change was very easy to make. Originally, there were only 48 critical care beds identified and planned for, but they have increased the number, and they've also increased the medical air compressors and the medical vacuum pumps to support that upgrade as well. One of the other things that they're working on, another feature that they implemented during the pandemic, was they plan to install IV tube sleeves or pass-throughs outside of each patient room that will allow nursing to set up IV pumps in the corridor and run tubes through the sleeves so that nursing can respond to pump alarms without having to waste PPE to go into the room. Also note in item number 1 is that decentralized station again, and then number 2, each patient room has a nurse server that's stocked from the outside, the quarter side, and then supplies are retrieved from the inside of the room to minimize that as well. And then a quick look at the mechanical systems. Again, mode 1 is normal mode for 16 isolation rooms throughout the hospital. It's all recirculated air, the color in green. Mode 2 is another mode for surge, and that's 32 isolation rooms. It allows that increase. And then you see mode 3, they have the ability as well for full exhaust on the inpatient units. And then lastly, I just wanted to close with not to forget the obvious. I think I mentioned earlier that the 2 hospitals will be within 2.5 miles from each other. And there are plans to convert the existing hospital to an outpatient strategy or outpatient facility. And I think this is a really keen strategy, given the past experience that hospitals have had with the loss of revenue, with outpatient surgeries and outpatient testing, et cetera. That mix will not exist anymore. So I think that's a nice position to be in, and a nice strategy for the system in these 2 hospitals. If in fact another future pandemic should hit us, that separation is pretty keen, and the distance between the 2 facilities is 2.5 miles. And so that concludes the Valley Health case study.
Thank you so much, Holly. We have a question for Donna. Post-COVID retrofits, how effective are the new commercial wall-mounted air purification system like Fellows Aramax? Do we really have enough data to risk the liability for adding these into projects to make clients feel safer?
Thank you, Stacy. So I would say first, of course, follow CDC guidelines, shoulder that with what's required by the current FGI guidelines. I can't specifically comment on specific equipment or manufacturers, but we know that the quality of the air, the speed of the air, filtration, et cetera, are all important, and it matters. I think you still have to continue to do your homework, and time will tell whether or not those particular solutions are successful. And when in doubt, I would say talk to an engineer.
Thank you, Donna. Are there any other questions from our audience participants? Now is the time to type them into the Q&A box at the bottom of your screen. All right, thank you. I just wanted to mention everyone who's participated in the program today, and it looks like 85 people, which is fantastic. We appreciate your interest. You each had an individual link logging in today, so you didn't need to enter any special passcode. We know that it's you based on the link that you used. Tomorrow you should be receiving a survey from us. Please complete that survey. And when we receive that survey back, your records will be submitted to AIA National to get you credit for today's program. And we hope that you register for more of our post-pandemic webinars. If you think of additional questions after this, you can always communicate us through messaging on social media or send a message to AIA New Jersey, and we will get it to our panelists. Thank you all for participating. Thank you to our 3 panelists. And we hope everyone has a safe and healthy rest of the year.
Thank you.